The arm fossa test is used to determine the segmental contact point for the supine PI ilium adjustment in Thompson. The arm fossa test is also used in SOT, but it's done a slightly different way, and it's used for a different reason. If in the prone position, my patient had a positive Derifield, which is a short leg with the legs extended, but in flexion, it's the long leg. The short leg becomes the long leg, and there's leg lag. There's resistance to pushing that foot towards the butt. I have a PI ilium on that positive Derifield side. So to conclude that you had a PI, you would have to have a positive Derifield leg check and leg lag on the same side. In some cases, when patients are unstable, they don't hold their prone adjustment very well, so adjusting them supine will probably work much better. Our segmental contact point will be somewhere along the inguinal ligament on the side of the PI. To find out where that segmental contact point is, we do what's called the arm fossa test. Raise your arm straight up, palm medial, elbow straight. I'm going to contact right in here along your inguinal ligament. Is that okay?
Yep.
Okay, so I find the ASIS, and with 2 fingers, I contact the upper ligament, and I ask my patient to hold the arm against a downward pull. Then I go slightly medial and more inferior towards the middle of the inguinal ligament, and we do it again. Hold, and her arm blew out. So this spot would be my segmental contact point for a supine PI. I would cock the table, place my inside or superior hand, in this case my left hand pisiform, on the inguinal ligament at the spot where it blew out. My fingers would aim away from the midline. I would stabilize with the other hand. I would get way down and aim towards her left foot with primarily an S to I line of drive, a little bit of lateral to medial, and just enough A to P to get the table to drop. You want to use very light tension. It has to be a very quick thrust and a very shallow thrust. And that can be done 2 or 3 times. That's good.